Hello everyone, I hope you all are fine and doing well. So we'll be continuing our important topics for the AMC MCQ examination, and these are the topics which you should not miss before entering in your examination hall. So let's discuss about our first topic, and before that we will discuss the case scenario which has been asked in your exam, and somehow it's very important for your examination, right? So talking about our first case scenario, with we have a 68-year old female, okay, and she has left adnexal mass, okay, left adnexal mass, okay, left adnexal mass. And on the physical exam, it seems to be a very complex, okay, it seems to be very complex mass, okay, it's an a complex mass, nearly around 8 centimeters, okay, and having both solid and cystic components, okay, solid and cystic component. Repeating again, there's a 68-year-old female with basically a distended abdomen, okay, and on the physical examination, there's a left adnexal mass. Then we went for a transvaginal ultrasonography where we found out that the patient is having a complex 8 centimeter solid cystic component uh, mass, basically a ovarian mass. Okay, ovarian mass. Then they are talking about which of the following combination of tumor markers. So here we need to remember what are the tumor markers which are important to see in a case of postmenopausal ovarian mass, and giving us the characteristics of malignancy on transvaginal ultrasonography. Okay, so what are the tumor markers which should be checked out in this very patient? So we'll be discussing this case scenario. Do we go for the uh, carcinoembryonic antigen and human chorionic gonadotropin, alpha fetoprotein, and human chorionic gonadotropin, CA125 and alpha fetoprotein, CA125 and inhibin, and then CA125, CEA, and CA19.9? What is the answer? You can take your time and answer it. You can just pause this video and try to answer it. Okay, let me wait for one more minute. Okay, now the answer is the E. Okay, CA125, CAE, and CA19.9, they should be checked in every patient who is suspected to have uh, what we say is complex ovarian mass, giving the characteristics of malignancy, a malignant ovarian mass. What are the three things which are very important for such cases? CA125, CEA, and CA19.9 according to RACGP. RACG and P. According to RACGP, they say that every patient who is having a suspected ovarian mass, suspected to be as a malignancy, we should be checking three things. Number one, the tumor markers we should be always checked are one of them is CA125, followed by CEA and CA19.9. These are the commonly used tumor markers. Okay, commonly used tumor markers, very important for your exam. This is the MCQ. Okay, let's move forward and talk about the ovarian cyst. You can see these are the healthy ovaries, then followed by the ovarian cyst. What is ovarian cyst? A fluid. There is a mass which is filled with a fluid, or rather we can say there's a sac which may be filled with the fluid, okay, in the ovary. So therefore it's an ovarian cyst. Therefore it's an ovarian cyst. Whenever there's a case scenario of the ovarian cyst, try to look at the characteristics of these ovarian cysts. Okay, according to IOTA, that means International Ovary Tumor Assessment Group ultrasound rules to classify masses as benign or malignant, and where we need to see that whether the patient is having benign ovarian mass or the malignant ovarian mass. They say that if it is unilocular cyst, then it's benign. What are the other features of benign masses? Presence of solid component, where the largest solid component presence of solid components where the largest solid component is less than zero point 0.7 centimeters. Presence of acoustic shadowing, smooth multilocular tumor with largest diameter of less than 10, no blood flow. They all are the characteristics of benign ovarian cyst. Benign ovarian cyst, no blood flow means there is no angiogenesis. No angiogenesis. Okay, there is no angiogenesis, and this is a characteristic of benign ovarian mass. What is M rule? M rule are used if the patient is having malignancy. Okay, malignant characteristics of the ovarian mass. If it is irregular, this is commonly used. This word irregular is commonly used in the examination. Any irregular mass is basically with the malignancy. If the patient is having ascites, patient with the adnexal mass with ascites means that the patient is having a malignant ovarian mass. Maybe there is omental caking, there is uh, spread of the tumor into the intestine, rather sorry, the peritoneum, resulting in the ascites and all. At least four papillary structures, if present, is a malignancy. Irregular multilocular. So this is smooth, but here, if it is irregular multilocular solid tumors with the largest diameter of more than 10, this is a characteristic of malignant ovarian mass. Very good blood flow means there is angiogenesis, and angiogenesis is a characteristic of malignancy. Then there's an other uh, criteria by which we can deduce that whether the patient is having risk of malignancy or not. That's called the risk of malignancy index. That's what it called as RMI. It uses iota, that is the ultrasound findings, number one, and then it uses menopause status, whether the patient is having menopause or not. Those patients who are having menopause, okay, they are at higher risk of having ovarian cancer over those who are premenopausal, okay, or young. So any patient who is having menopause with ovarian adnexal mass, okay, adnexal mass, we need to check the tumor markers. This is what you need to remember. Any patient. So I am writing it. Okay, we'll discuss about this in the next slide. So yeah, basically what I was discussing about the risk of malignancy index, where we use a criteria of ultrasound findings, menopause status, and then tumor marker of CA125 findings. If the ultrasound findings include, and what are the points given to each? Multilocular cyst, 1 point should be given. Solid area, 1 point is given, and then we have the metastasis, ascites, and bilateral lesions, and each basically contains 1 point. Okay, if the patient is having 2 to 5 features altogether, then we can give three points, okay, in that patient, but the features should be at least 2 to 5. Menopausal status, if 1 point should be given if it's premenopausal, and 3 points if the patient is having postmenopausal uh, status. See, this is very important again. Then we have if the patient is having CA125, and we need to look at the actual levels. Rather, if it is less than 30, that's okay. If it is more than that, that's a problem. Okay, that's basically a problem if it is more than 30. So here they have given us the what we say is example. There's a for postmenopausal woman with left multilocular. See, multilocular it itself giving us 1 point, and postmenopausal is itself giving a 3 point. Okay, and CA125 is in this patient is 40. So 1 point for ultrasound, 3 points from postmenopausal. 40 should be multiplied with all of this. It will come up 120, and therefore the patient should be referred to the gynecology. If any patient who is having RMI index of 40, okay, more than 40, we need to refer the patient. We need to refer the patient. We will see it over here. And remember one thing: if the patient is having adnexal mass, if the patient is having adnexal mass, what is the next? What is the next investigation? It is none other than the ultrasonography. Okay, ultrasonography. This is what you need to remember. If the ultrasonography is not present in the options, you can think about MRI. You can think about MRI. Okay, you can think about MRI. So complications of ovarian cyst include cystic rupture. Okay, it includes cystic rupture and torsion. And cystic rupture and torsion. Torsion is a gynecological emergency and it requires urgent review. So remember that the patient who is having ovarian cyst, and if the cyst is large, it can have a rupture or it can result in the ovarian torsion. Remember that. How can you differentiate between that whether the patient has ovarian cyst rupture versus ovarian torsion? Okay, how can you differentiate? You can differentiate it on the basis of blood pressure. If the patient's blood pressure is decreased, that means the patient is hypotensive. Okay, hypotensive with instability. The patient is having left or the right iliac fossa pain, adnexal pain, or the right or the left iliac fossa pain. The patient is unstable. Patient is having hypotension. Then it is a case of ovarian torsion. If the patient is having left or the right iliac fossa pain with normal BP, okay, then yeah, you can suspect that the patient is having ovarian cystic rupture. So MRI may be useful in assessment of large cysts that are difficult to assess on ultrasound. Okay, so how do we approach in all the patients? If the patient is premenopausal, okay, ovarian cyst on ultrasound, ovarian cyst on ultrasound. You found out, okay, the patient had, you went for the physical examination and there was an incidental adnexal mass, okay, adnexal mass, and in this patient you went for the ultrasonography. Now remember, think about that. If the patient is premenopausal status and the size of this the size of this adnexal mass or the ovarian mass is less than 5 centimeter and it is simple, okay, it is simple and echoic, uh, and the patient is asymptomatic, we have to reassure the patient no further action should be required. Then if it is 5 2, so it is less than 5, remember it, less than 5, okay, less than 5, it comes in the first, and the patient should be asymptomatic. If it is 5 to 7 centimeters, simple asymptomatic of 5 to 7, okay, 5 to 7 centimeters, and if the patient is asymptomatic, we need to repeat the ultrasound in 3 to 4 months, and if there is no change of decrease in size, or the patient can have increase in size is, and the patient is now having the symptoms, that means there's enlargement and the patient is having symptoms, we can refer the patient. Okay, at the time we have to refer the patient if patient falls in this criteria. If there is no change of decrease in size, you can again go for the follow-up. You can go for the repetition of the ultrasonography. At the same time, if it is more than 7, if you can see it over here, if the patient is having a cyst of more than 7, or the patient is symptomatic, or it is complex in nature, we have to refer the patient in first hand, because this is what we say is the characteristics of malignancy. Enlarged cyst, more than 7, okay, more than 7 in premenopausal. Please remember this. I'm emphasizing that any patient who is premenopausal, not in the menopausal status, we have to refer them only when it is more than 7 centimeters, or the patient is symptomatic, or it is having some malignant characteristics on the ultrasonography. If it is less than 7, we can, and the patient is asymptomatic, we can think about the repetition. We can think about the repetition of ultrasonography, go for the follow up and all. And if it is less than 5 and no symptoms, we can reassure the patient and discharge the patients and home, and just reassure the patient. But there is this trick which is always played by the AMC, is that they will give a case scenario of postmenopausal woman and having left adnexal mass. You went for the ultrasonography and they will tell you that it is 3 centimeter. It is just 3 centimeters. uh, uh, it is just 3 centimeter ovarian mass. Okay, just 3 centimeter. If you'll just, you know, uh, go in a rush, if you'll just answer that question in a rush, and without knowing that any patient, you may think that okay, we can go for the follow-up, a repetition of ultrasonography, or you just reassure the patient, because at the time you may not be able to recall this very table in a good way. So our basic understanding should be that any patient who is having postmenopausal ovarian mass, whatever it is, whether it is showing us the characteristics of benign ovarian mass or the malignancy, every patient who is having postmenopausal mass, adnexal mass, should undergo for the ovarian tumor markers. Important one is CA125 and then CEA and CA19.9. According to RACGP, these three should be commonly used in every patient who is having adnexal mass. And then we calculate. Okay, we know what is the what is the formula in order to check the RMI, right? That is the risk of malignancy index, where we went for the ultrasonography characteristics, right? Then we check the menopausal status, and then we multiplied it with one and all the CA 125 levels. And if it was, then we go for the check. If it is less than 25, sorry for this, I told you more than 40, it should be more than 25 rather. So if it is less than 25 or less than 5 centimeters, plus less than 5 centimeters, simple unilateral, and the CA125 is less than 30, we can think about the surveillance. We can think about the surveillance. We need to repeat the ultrasonography with CA125 in 3 to 4 months. If there is resolution of cyst or decrease in size, no need to follow up. If there is no change or increase in size or development of suspicious features, we can refer to the gynecologist. If RMI is 25 to 200, we have to refer the patient, just we did like here, okay? And if it is more than 200, we can refer the patient and go for the staging of laparotomy. Here, there is referral to the gynecologist or the gynecology oncologist for the laparoscopy, but here we have to, if its RMI is more than 200, there we have to check for the staging also. We'll talk about the staging also in meanwhile. We have to discuss about the pregnancy woman with the ovarian cyst. Basically, this is what they ask in your exam. Please remember this. This is the MCQ recall question. Ovarian masses are usually an incidental finding during the pregnancy. The majority of these masses are benign. Okay, they are benign. They say that majority of the masses are benign and can be managed expectantly as at least 50% resolve spontaneously during pregnancy. Okay. The reported rate of complications with expectant management is less than 2%. If a cyst is identified early on a dating ultrasound, a repeat ultrasound. Okay. If a cyst is identified early on a dating ultrasound, a repeat ultrasound should be done at 12 to 14 weeks. Okay. Please remember this to check if it has resolved or not. Operative intervention, they will ask you the patient is having ovarian mass and when we should go for the operation. Okay, when we should go for the oophorectomy or whatever it is. Operative intervention is indicated if malignancy is suspected, if there is an acute complication like torsion. Okay, so any patient who is having malignancy, suspected malignancy, even during the pregnancy, we need to go for the operative intervention. Or the patient is having a cystic mass, which as the patient is having this ovarian cystic mass, which has gone under torsion, or if the size is likely to be caused the obstruct to cause likely to cause obstetric or other problems. The ideal timing of operation, very, very important for exam, is after the first trimester. Basically, there is a guideline which says about the safe zone. Okay, safe zone, which is basically after first trimester. Okay, after that you can go for the operation, that means in the second second trimester is the best time where we can go for the operative interventions, oophorectomy, or and we can also take out the other parts which are being involved by the malignancy. It can be either salpingio oophorectomy if the fallopian tube is also involved. So, but one important point is that second trimester is what where we go for the operative interventions. As this decreases the miscarriage rate and teratogenicity, the risk of ovarian cancer in pregnant women who are noted to have a cyst on ultrasound is less than 1%. So here we have a question. I will just give you a gist about it. This is a patient who is, can just go directly over here, and that the patient is having some constipation. There is a loss of weight also. There's a blotting. Okay. And there's a firm irregular mass palpable on the left lower quadrant. So basically the patient is having, if this is the if this is the fallopian tube and this is the right side and this is the uterus and then this is the left side, and on the left side there is now this mass. Okay, it is basically irregular. Okay, this is irregular. Okay, this is irregular mass and a firm mass. And we went for some investigations where we can see that the patient is having CA125 is elevated, which is more like it's really high. CEA 2.5. Okay, again it is elevated because, oh no, it's normal. Okay, CA 19.9, it is 45, again elevated. So yeah, we can think about that the patient is having malignancy, an ovarian malignancy, because the characteristics, as you can see here, irregular mass, the patient is postmenopausal, and the patient is having elevated CA125. So if we go for the RMI, it would be irregular mass, it would be 1, and then we will have postmenopausal 3, and then into 850, it would be really, really high. Okay, it will be really, really high. So RMI is really high. It would be more than, of course, more than 200. Therefore, we have to refer this patient for the gynecology, right? But yeah, they're not asking about this. They are saying that we went for the CT scan and CD of the chest. which shows no evidence of the metastatic disease, because as you remember, every patient who is having more than 200 RMI, we refer the patient and go for the staging. So that's what they have already done. They went for the staging with the CT scan. They went for the CT of abdomen and the pelvis, which shows a bilateral complex ovarian mass. Okay, it's bilateral. Omental caking is there. So basically, it has involved the peritoneum. Okay, but the chest is okay. Moderate ascites is present, multiple peritoneal deposits throughout the abdomen and pelvis. Okay, there's metastasis to the peritoneum basically. And also there is involvement of the pelvis also. Which of the following is the most likely staging of this? Okay, basically they are talking about the staging. So they are talking about the staging. They're talking about, let's discuss about the staging. Let's discuss about the staging. And here we go, and we'll discuss about the ovarian staging. Okay, ovarian cancer staging. Ovarian cancer staging, that's very important. So any patient, very simple, very simple. I'll try to make it very simple for you, and let's do it. So if you can see, if it is, let's make it with something different color. We will use some different color, just looking at, okay. So we have this fimbriae, and this is the ovary. Now this is the fallopian tube. This is the ovary, right? This is the ovary, and here we have this uterus and all. Again, we have fallopian tube. We have fimbriae, and then we have this ovary, and we know that this is the sac. This is the S5. Okay, the last vertebrae of the sacrum, and this is just like this. Then we have sacroiliac joint. Okay, pardon me for any no bad diagram. This should not be looking like this. Okay, this is basically the pelvis, because the uterus is the part of the pelvis, right? So we'll try to make it as simple as this. Okay, now we are pretty sure that this is the uterus, which resides in the pelvis, right? We all know that. Let me make it a little bit smaller. Okay, now this is the outer skin. Okay, this is the outer skin, and this part, this is basically the marker for, this is a landmark for the abdomen. This is basically the abdomen, right? Abdomen. And now this is the diaphragm. This is the diaphragm, and above the diaphragm we have none other than our lungs, right? We have none other than our lungs, right? We have none other than our lungs. Now let's talk about now the staging. If the patient is having the involvement of the tumor and the malignancy, it is only involving the ovary and the fallopian tube, then it is a stage one. Then it is stage one. Okay, stage one, right? Stage two. What is stage two? Stage two is if same this malignancy, it involves the uterus, it involves the uterus, or it goes to the other part, it goes to the other part, or it involves the pelvic organs. What are the pelvic organs? Urinary bladder, right? Urinary bladder. It involves sigmoid, rectum, or even or the lower part of the ureter. Okay, lower part. This is what you called as second stage. Second stage. And if same, it there's metastasis, and it goes up, and involves the abdominal organs, like for example the peritoneum, right? We were talking about the peritoneum. If it goes and it involves the peritoneum, there is involvement of the peritoneum, there is involvement of the stomach. Okay, these all, there is involvement of the small bowel. That is all stage 3. So abdomen is the stage 3. What is stage 4 then? Chest is the stage 4. Chest is the stage 4. Right? Now if we'll go back and we'll see that the CT chest shows no evidence of metastatic disease. Okay, that means CT chest is okay. So chest is okay, therefore it's not as stage 4, right? Then they say that there is no evidence of the metastatic disease in the chest. CT scan of the abdomen. We went for the CT scan of the abdomen, and what is that showing? Let's check it over here. What it is showing in the abdomen, abdomen of the pelvis, and the abdomen. CT scan of the abdomen and the pelvis is showing bilateral complex ovarian mass, and mental kicking is also there, moderate ascites also there, multiple peritoneal deposits throughout the abdomen and the pelvis. That means we are talking about stage 3, and that is the answer, right? And that is the answer. Done. Now with this, I hope this is clear. If they will give you the same question and only pelvic organs are involved, you can go for the stage 2. If only fallopian tube and the ovaries involved, it's a stage 1. Abdomen is involved, stage 3. Chest is involved, stage 4. Done. Then we have another question over here where the patient's name is Christine. She's 48 years old. Whenever they say 48 years old, that means it is a perimenopausal woman. She's near about to get into the menopause, okay? And she's presented to you to your GP clinic today with complaints of heavy and irregular periods over the past 5 months, and she reports that her menstrual cycles have always been regular, occurring every 28 days, lasting for 5 days until recently. Christine has no significant past medical history and denies any previous gynecological issues. Her last cervical test performed 6 months ago was reported as normal. On physical exams, there are no abnormal findings. So the following is the most likely cause of Christine's presentation. So what is the issue? The patient is having heavy and irregular periods, right? Heavy and irregular periods in the perimenopausal woman. It is basically your end ovulatory cycle. This is your answer. Always and always remember this. This is your answer in a patient who is having who is perimenopausal woman complaining of heavy and irregular periods. Heavy and irregular periods. It is basically your end ovulatory cycles. Please remember this. So we will be now. Uh, let's read the explanation of this very question. So, given Christine's age and her previously regular cycles, the most that means option C, the most likely cause of her erratic bleeding would be an ovulatory cycles. Recall that in the perimenarchal period, first few years after menarche, and in the perimenopausal period, the menses become irregular and ovulatory, and they are the most common cause for the heavy menstrual cycles in both the events. That means in the initial months of the menarche and later before the menopause. Okay. Now, basically, this topic is covered in your gynecology, but uh, because this is really important for your exam, I just want to mention about some of the few points which you need to know. Uh, Whenever we talk about the menopause, we need to learn what are the sign symptoms of the menopause. It could be the symptoms could be divided into five categories: vasomotor, psychological, urogenital, musculoskeletal, and the skin change. If we talk about the vasomotor, it is hot flashes, night sweats, palpitations. If we can see among all of these, 80% of the patients would have these symptoms of hot flashes. Migraine could be one of the possibility of the symptom of menopause. Irritability, depression, anxiety, tearfulness, unload feeling, decline in libido, atrophic vaginitis. Okay, most common cause of dyspareunia. And then we have vaginal itching, burning, and of course the patient has dyspareunia also, bladder dysfunction, stress incontinency, where we can ask the patient to go for the Kegels exercise, musculoskeletal, muscular aches, joint aches, skin change like dry skin, formication, breast glandular tissue atrophy. So talking about the treatment, because the treatment is after the menopause, what decreases in the patient is estrogen, right? Estrogen. When there is decrease in the estrogen, resulting in these sign symptoms, all of these sign symptoms are basically due to decreased estrogen, right? So, what should be the treatment? Treatment is to replace replacement of estrogen, right? So, therefore, we go for the menopausal hormonal therapy, which includes the estrogen basically, and base it on the uterus status. Okay, we can add progesterone with estrogen. Why do we add progesterone with estrogen? Is estrogen alone can result in endometrial hyperplasia, and eventually patient is having a risk of endometrial carcinoma. So the reason why do we add progesterone with the estrogen is to decrease the risk of endometrial carcinoma. According to NICE guidelines, they say that menopausal hormone therapy was one of the most appropriate treatment for the menopausal symptoms. MST improves bone density and reduces fracture. CVD risk was not increased. See, not increased among women who use MST menopausal hormonal therapy and may be reduced in normal target population. Venous thromboembolism risk was increased among women using oral MHT, but not among women using non-oral therapy. Okay, so those patients who are taking oral MHT, okay, they have high risk of having venous thrombus embolism like DVT or pulmonary embolism later. But those who are having like patches, okay, or intrauterine devices, they have less chances of venous thromboembolism. Breast cancer risk was not increased. So please remember this: breast cancer risk was not increased for women taking estrogen, okay, but was increased with long duration use in women taking combined estrogen and progestin therapy. The effect reduced after ceasing the therapy. So, what is the practice step? And that alone, estrogen does increase the risk of endometrial carcinoma, but those who are taking estrogen as an alone, without taking these estrogen plus progesterone as a long therapy, the risk of breast cancer was not increased. And what is the practice tip? In women without contraindications, MST carries few risk if initiated before the age of 60 or within 10 years of menopause. So, prescription consideration. Those patients who are in the perimenopausal women, like we had in this very case, we can go for the cyclical menopausal hormonal therapy. But those who are like postmenopausal, we have to go for the continuous menopausal hormonal therapy. So the cyclical menopausal hormonal therapy again use it for those who have symptoms in the perimenopausal phase. Those who are postmenopausal, we have to go for the continuous MHT. Please remember this. Now, based on menopausal hormonal therapy options, this is the MCQ. Okay, this table is used by the AMC, and they usually ask a question about the MHT from this very table. They say that if there is a patient who is having uterus intact, we can go for the transdermal estrogen plus progesterone patch. Okay, those with the uterus intact, those with the uterus, don't have to consider oral treatments. We consider transdermal estrogen plus progesterone patch. Those who are or we can go for the transdermal estrogen or oral patch, but importantly progesterone patch is important rather than the oral ones. Then transdermal estrogen plus LNG IUD, that is levonorgestrel IUD. We can go for the oral plus oral progesterone, but they are not answer for your exam. Okay, post hysterectomy uh, we can can skip the progesterone. We can directly go for the oral estrogens because the risk of endometrial hyperplasia is not over there because uterus is already removed. We can go for the transdermal estrogen or tibolone also. Mostly they ask you this, that the patient is having post hysterectomy was done 3 to 4 years ago. Now, which of the following should be used? It is oral estrogen can be used. If MHT is required beyond 60 years, oral estrogen and tibolone are not recommended due to increased stroke risk. Very important. Contraceptions after menopause. If the patient is over 50, contraception indicated for 12 months. If she is under 50, like 49, contraception is indicated for 2 years. Duration of MHT, no mandatory limit to use of MHT provided contraindications do not emerge. This is very, very important. Duration of MST is not there is no limit for that. Okay, then we'll talk about the kidney stones. Any patient with a stone size of less than, okay, of less than 6 mm, less than 6 mm, and it is at any location, we can go for the conservative treatment for 6 weeks. Okay, 6 weeks. If the stone is in the distal, see, for example, this is the kidney. Okay, this is the ureter, and this is now the bladder. Okay, they say that if there is any stone which is of less than 6 mm, according to RACGP, they say that less than 7 mm, any stone of less than 7 mm, we can go for the conservative treatment. Conservative treatment. Okay, where we ask the patient to go for the increased hydration and all. And any patient who is having a kidney stone and that is near the distal part of the ureter, we can go for the conservative treatment. Plus we add your alpha 1 a agonist antagonist, that is tamsulosin. Okay, tamsulosin to aid the passage of the kidney stone. Then uh, if there is any stone which is with the size of 5 to 7 mm, 5 to 7 mm, okay, 5 to 7 mm, and the stone is located in the renal calyces or renal pelvis, renal calyces or renal pelvis, okay, renal pelvis, and the size is 5 to 10 mm, we can go for that is a indication for the usage of ESWL, that is that is extracorporeal shockwave lithotripsy. Okay, the for the usage of for the usage of for the usage of for the usage of ESWL, 2 points should be always remembered. Number one is that the stone should be at one of the locations either in the renal calyces or in the renal pelvis. Plus, the size should be of 5 to 10 mm. If, for example, there is a kidney stone which is like 5 to 7 mm and the stone is not passing, okay, it's not passing out. So, therefore, after 6 weeks, and the stone is near the renal calyces or renal pelvis, instead of using the laser lithotripsy or anything else, we can think about the ESWL. But the important point is that these two criteria should be fulfilled. That's important. Now, if there is any stone which is less than 2 centimeters and failed conservative management, less than 2 centimeters, any location, that means it is at any location, preferably distal, we can go for the laser lithotripsy, plus we add the ureteroscopy. But what is the indication for the usage of ESWL? Again, if it is 5 to 10 mm, but it is located in the renal calyces and renal pelvis, at that time we can go for the ESWL. It is basically rarely used in Australia, but yeah, if the two criterias are fulfilled, we can go for the ASWL. If it is more or equal to 2 centimeter at any location, percutaneous nephrolithotomy is what we use. Remember that it is more or equal to 2 centimeter. More or equal to 2 centimeter. So 2 centimeter, go for percutaneous nephrolithotomy. Now, talking about the headaches very important for your exam. And what they ask you is that they will ask you about the treatment part. Okay, remember that any patient who is having, for example, cluster headache. Okay, in the patient who is having cluster headache, location of the headache, the location of the pain will be unilateral and it would be retroorbital. Okay, retroorbital, very important. With the cluster headache, basically there are other features in these patients which are found, like the patient can have even meiosis also. Okay, patient can have even meiosis also. There sometimes that the patient of cluster headache will tell you that, doctor, it seems like there is a nail which is like someone is inserting a nail or a sharp pen behind my ear, behind my orbit. Okay, and the patient can have meiosis also. Done. And what is the duration? 15 minutes to 3 hours, and it is repetitive. And the patient can have excruciating periorbital pain, suicide headache with lacrimation, right? The patient can have lacrimation and rhinorrhea, may present with Horner syndrome, very important. Okay, most common in the males. So it can come with the, like I said, in the meiosis, the patient can have even anhidrosis and the shrunken eyes. That means the patient who is having cluster headache can come up with the Horner syndrome also. Treatment: acute, go for the 100% oxygen or sumatriptan. For the prophylaxis, we can think about the verapamil. Very important for your exam. Okay, very important for your exam. Migraine, again, unilateral, 4 to 72 hours, pulsating pain with nausea, photophobia, or phonophobia. May have aura also due to irritation of cranial nerve 5, meninges, or blood vessels. There's a release of vasoactive neuropeptides, substance P, calcitonin gene related peptides, which result in the vasodilation, resulting in the unilateral pulsating uh, pain and pulsating 1 day duration, unilateral nausea and disabling pain. Acute patients should go for the, at an initial step, go for the NSAIDs. Okay, or we can, and then if it's not, patient is not responding, we can think about the triptans. We can think about the dihydroergotamines, not used in Australia. Prophylaxis, lifestyle change like sleep, exercise, diet, beta blockers, that is propanolol, very important for your exam. Amitriptyline, topiramate, valproate, botulinum toxin. So all these are the prophylaxis for the treatment of migraine. Please remember this. Tension. So tension headache is bilateral, more than 30 minutes of duration, typically 4 to 6 hours. It's the pain is constant, steady. It looks like a band is covering, as you can see over here on the frontal part. No photophobia, no phonophobia, and no aura. Analgesics should be used like NSAID, acetaminophen. Prophylaxis TCAs are used as a prophylaxis and behavioral therapy. There's other important point is that other causes of headache include subarachnoid hemorrhage, worst headache of my life, meningitis, hydrocephalus, neoplasia, giant cell temporal arthritis. What is the treatment for the giant cell temporal arthritis? It is corticosteroids because it helps and the patient and prevents the patient to undergo for the blindness. Compared with the transgeminal neuralgia, which produce a repetitive unilateral shooting shock like pain in the distribution of cranial nerve 5 triggered by chewing, talking, touching certain parts of the face, and it lasts typically for seconds to minutes, but episodes of increase in intensity and frequency over time. First line treatment is carbamazepine. Very, very important for your exam. So basically I uploaded a question for the prophylaxis of the cluster headache, and the answer was verapamil at that time. And sometimes they may ask you the acute treat management. It's 100% oxygen. Okay, and what else? Um, now we'll be covering the management part of management part of migraine management part of migraine as per ETG. As per ETG, that is therapeutic guidelines, they say that if there's any patient who is coming to us with pulsating unilateral pain, there is thrombing pain, which is like 4 to 72 hours, as you can see over here, and you are thinking that the patient is having migraine. Okay, the patient is having migraine. What is the first step? What is the first step is that you ask the patient to go for, to take a rest in a quiet room. That is the first step which you will suggest the patient. You ask the patient to, do cold packs, use the cold packs over forehead, okay, over forehead and occiput and neck and then the shoulder. So you advise these patients to take such steps. Second step is to take NSAIDs, okay? To take NSAIDs like aspirin, PCM, plus we add these patients one important drug that is NSAIDs. That is antiemetics, and these antiemetics are used in these patients because these patients have gastroparesis also, right? These patients are gastroparesis also. We need to add a drug which is a prokinetic, which is an antiemetic. So for that reason, we use metoclopramide. Metoclopramide can be also used in the pregnancy. Any patient who is having migraine pain in the pregnancy, we use the PCM, because among the NSAIDs, if we don't involve the paracetamol in the NSAIDs, therefore we can, because all the NSAIDs diclofenac, aclofenac, mefenamic acid, ketorolac, like they all are contraindicated in the pregnancy. But here I'm saying that we can include PCM plus metoclopramide even in the pregnancy if the patient is having migraine. And the last step is go for the triptans. Okay, triptans, sumatriptan, naratriptan, rizatriptan, they all are the treatments for the migraine in patient. Remember that triptans can be used in any patient who is older than 6 years. Those who are less than 6 years, never ever use that. And in the pregnancy, as I said, treatment is same. Okay, but instead of using other NSAIDs, we rather use simple our PCM plus metoclopramide. Okay, that's your MCQ. Okay. Very, very important for your exam. And if it's not, controlling the symptoms in the patient, sumatriptan is the only triptan which can be used, or it is safe in the pregnancy. Okay, it's safe. So basically, what I said was that treatment for the pregnancy is same. If it's not responding to the PCM plus metro, we can think about the sumatriptan. If any of the triptans should be used, it is the sumatriptan. And talking about a child, if there is a child, like for example, this is a child and having unilateral headache, okay, uh, pounding headache, unilateral headache, or you are pretty sure that the patient is having headache, according to EDD, and the ibuprofen is what should be used over PCM, okay, over PCM. And this is all for your migraine part. Migraine part done and dusted. Talking about the seizures, very important for your exam. Uh, to be honest, from last 5 to 6 months, they have not asked any question from the seizures. And one of the questions they usually ask is they put a question of a patient who is having, near about hypoglycemia, like less than 5.5 but more than 3, right, in a child basically. And then they will ask you that the patient is having blood glucose levels of like 3.5 moles, and at the same time the patient is having seizure. Which are the following investigation, which are the following management should be done first? So there be like patient should be treated for the hypoglycemia, patient should be treated for the seizures with the levetiracetam, and that's the answer. Patient should be given levetiracetam if the patient is having 3.5 glucose levels and with coming up with seizures. Because if you read the RCH guidelines, they say that any patient who is having less than 2.5 millimoles per liter of glucose levels, only that can result in seizures. Other than that, if it is more than that, it's very rare to cause seizures in a patient. But yeah, it's always better to rule out the hypoglycemia in a patient. Like for example, there is a child coming up to you with seizures, you have to check the hypoglycemia first, right? So let's talk about the seizures. What is basically a seizure? Very simple definition that it is uh, characterized by the synchronized, like, high frequency neuronal firing, right? That is what results in the seizures, right? This is not like a rocket science for us. So we know the definition is very simple, that the patient is having synchronized high frequency neuronal firing resulting in transient abnormal electrical brain activity, and which eventually causes change in behavior, right? Sensation or consciousness. So these three things should be always checked out. After we know what is a seizure, then we should try to learn what is the definition of epilepsy then. What is the definition of epilepsy? Epilepsy is a disorder of recurrent seizures. Recurrent seizures are, as per the guidelines, we can say any patient who is having at least two unprovoked seizures is what we called as epilepsy. Okay, this is what we call as epilepsy. Then we have another definition, that is what is status epilepticus. What is status epilepticus? Any patient who is having a seizure which is lasting for more than 5 minutes, which is lasting for more than 5 minutes, or there's a recurring seizures. Okay, there's a recurring seizures, or we can say there is more or equal to two seizures without full recovery in between. Okay, in between. That's basically a patient who is definite for we have to go for the clinical management in such patients. So talking about if there is any patient who is now coming up with the seizures, the seizure, what are the types of the seizure? Either it is a partial or focal seizure, right? Or the patient can have generalized seizures. So the partial seizure will involve only a particular part, like for example, a hand, right, a forearm, or the arm, or the patient's foot. So that is what we call as partial focal seizures. Okay, partial focal seizures. In the generalized seizures, the patient will have the involvement of the whole body, right? Now, partial seizures, once the patient is having partial seizure, you should remember that we need to check, okay, if the patient is having partial seizure, like for example, the hand is moving, okay, and he is not cautious about his hand. He is not looking at his hand and seeing, okay, oh my god, my hand is moving, right? He cannot, he's unconscious, he's not, he's having impaired consciousness about the movement of the hand. That is what we call as simple partial seizure. Okay, if there is impaired, sorry, that's what we call as complex partial seizure. If the patient is having impaired consciousness, that is what we call as complex partial seizure. But if there's the same patient, like for example, this is the patient and his hand is moving, and his hand is moving, okay, his hand is moving, and at the same time he is looking at his hand. Okay, he's looking at his hand and saying, oh my god, my hand is moving. Okay, my hand is moving. At the time, that is what we call as the patient is not having impaired consciousness, rather the patient is conscious about the movement of the hand. That's what we call as simple partial seizure. Simple partial seizure. At the same time, you should remember that this partial or the focal seizure can be, it can transform, or it can be converted into secondary generalized seizures, basically towards a tonic clonic seizure. And this should be in your mind, this should be in your mind. So any patient who is having the hand movement first can eventually, this can be eventually transferred into the, it can be converted into the tonic clonic, that is the generalized seizure. So focal seizure, the first point is focal seizure can be converted into generalized seizure, and more importantly, the tonic-clonic seizure, tonic-clonic generalized seizure, right? Tonic-clonic generalizes seizure. If the so we have simple question. If the consciousness is intact, that is what we call as simple partial seizure. If the conscious is not intact, that is impaired consciousness, that is what we call as complex partial seizure. Remember that those patients who have complex partial seizure, they have auditory, they can have auditory hallucinations, and they can have olfactory hallucinations. Okay, auditory hallucinations or olfactory hallucinations. Make sure you remember this. Where do we see the Jacksonian march? It can be seen in the simple partial seizure. Okay, Jacksonian march. Then we have Post-ictal confusion is seen in, it is seen in complex partial seizure. Post-ictal confusion. Okay, post-ictal confusion is seen in the partial complex seizure. And if they ask you that if the patient is having focal seizure, okay, focal seizure, be it be like with awareness or without awareness, that is simple or complex partial seizure, the treatment is very important. That is carbamazepine. What was the other usage of the carbamazepine? It was used for the, yes, trigeminal neuralgia. Okay. What is the side effect of carbamazepine? One of the most important side effect of the carbamazepine is that it results in the syndrome of inappropriate ADH. Should remember this. So those patients can have dilutional hyponatremia, very important. Any patient who is on the carbamazepine, check out the electrolytes. If the patient is having any sort of symptoms related with the low levels of sodium, which we had discussed in the endocrine part, um, so you have to manage the low levels of sodium also if the patient is on the carbamazepine with the hyponatremia. Remember that the patient with the simple partial seizure, that means the patients have the focal seizure, right? The patients have the focal seizure, and sometimes this complex partial seizure is converted, or it is sometimes if it results, if it recurs, okay, if the patient's having complex partial seizure initially, if it recurs, it comes back as a case of lobe epilepsy temporal lobe epilepsy. That is the reason the patient can have auditory or the olfactory hallucinations, because that area is related with the temporal region. Then we have generalized seizure. What are the types of the generalized seizure? The patient can have tonic seizure, myoclonic seizure, atonic seizure, or absence seizure, right? So these are the different types of generalized seizure. Remember that if the partial seizure is converted into, remember that if the partial seizure is converted into secondary generalized seizure, the treatment of choice is valproate. Okay, treatment of choice is valproate. Like, let me give an example over here. If, for example, there is a patient, this is the patient, and he is having focal seizure. He is having focal seizure. Okay, the in he is having focal seizures at home, and now the time he came to you in the hospital, in hospital, this has been converted into generalized generalized seizure. Generalized seizure. Definitely, you will treat the patient with initially with the valproate to terminate the seizure, and once it is terminated, then you will ask the history. You will ask history in the patient, and if the patient says that yeah, it was focal, first it was focal, then you put the patient on the prophylaxis treatment for the focal seizure, and that is none other than carbamazepine. Carbamazepine. That's the way how you treat these patients. First, you terminate the seizure either with the valproate, or you can use the Levitera. If the patient is old, if the patient is child, we can use Levitera. Uh, and then we ask the history. Once we ask the history, initially we put the patient on the Levitera, and then we ask the history in the patient. And if the patient says, yeah, it was first focal, then it got converted into generalized, it got converted into generalized seizure. That means the whole body was then moving. I will put the patient on the prophylaxis treatment as a focal, and that is the carbamazepine. That is the carbamazepine. Now, going back over here, the tonic-clonic seizure is what we call as grand mal seizure. It is alternating stiffening and the movement of the whole face. That means a tonic, that means there is stiffening of the whole body. Clonic, then there is the laxation of the whole body. That is contraction, relaxation. Contraction, relaxation, that is what we called as uh, tonic-clonic seizure. Loss of consciousness is seen. Post-ictal confusion is state is also seen in the tonic-clonic seizure. Tonic means that the patient is only having stiffening. Myoclonic means quick and repetitive jerks in the muscles of the patient. Atonic means there is a drop seizure, right? Patient falls. What is the difference between the absence and the atonic seizure? Is that in the absence seizure there is a blank stare and there is no post-ictal confusion. There's just a blank stare, but the uh, what we call as the balance, okay, the body balance is maintained. It is maintained. There is no dropping. Okay, there is no the drop if the patient is having this blank stare and the patient then drops. It is not an absent seizure, rather it is an atonic seizure. Rather it is an atonic seizure. So it drops. Okay, falls to the floor. It's most commonly mistaken for fainting, but you should remember that these patients should be ruled out as a case of atonic seizures. Done with this, we are just doing the seizures and not the epilepsy. Please remember this. This is just the seizure part which we are doing. And if there is first episode of any of these and the patient is adult, in the first episode of seizure in an adult, we should go for the imaging. We should go for the imaging. If the patient is child and it is a first episode and it is a first episode of seizure, we have to we have to check the hypoglycemia, of course. We have to check the electrolytes. Okay, these things should be done. Patient with the first episode of seizure and the patient is adult, go for the imaging. Then later on, go for the electrolytes, hypoglycemia, and all. If the patient is a child, look at the um, look at the hyponatremia or the electrolyte imbalance. Plus, look at the hypoglycemia also because they increase the risk of the seizures. Also, to go for the pregnancy test if the patient is female and all. Okay. Once we are done with the seizure part, now let's discuss about let's discuss about one and only mm, mm, juvenile myoclonic myoclonic epilepsy. Okay, juvenile. We are talking about now the epilepsy. Okay, if there is a patient who is having juvenile myoclonic epilepsy, what would be the case scenario? What would be the case scenario? Okay, the case scenario would be they will come to you, they will say that, doctor, my baby is having these myoclonic quick repetitive jerks early in the morning. Okay, early early morning epilepsy. Early morning epilepsy is seen in juvenile myoclonic epilepsy, and remember that it is triggered by light. And important point is that the patient conscious level is preserved and treatment is none other than valproic acid. Valproic acid. Okay. treatment is none other than valproic acid. Valproic acid. That's very, very important. Then what else should we do? Once the patient is having seizure, okay, once the patient is having seizure, and if seizure is converted into epilepsy, okay, if the patient is having now epilepsy, the patient had seizures, now it is recurring. There are like more than two episodes, at least two unprovoked seizures, and the patient is having now recurrent seizures. That is what we called as epilepsy. And once the patient is coming to us with the epilepsy, we have to diagnose it clinically, number one, plus we have to support it with the investigations also. Like, so diagnosis clinical, so we have to add what? EEG also, which supports, it supports the diagnosis, but normal EEG do not exclude the diagnosis of epilepsy. We can include the MRI, it is useful but cannot confirm the diagnosis. And again, so therefore we come back to the clinical diagnosis of the epilepsy. We take it from the history from the patient. Okay, so when we're talking about the each part of the seizures, and we discussed about the different types. Now we'll discuss about, we talked about the juvenile myoclonic epilepsy, which can be, it is basically the myoclonic. If the patient is, a patient's first episode was myoclonic seizure, this can be converted into juvenile myoclonic epilepsy, which can be triggered by the none other than the light, the morning light. Okay. I remember one important point, and that is, if there is any patient, okay, if there is any patient who is having like absence seizure, okay, because we discussed about the treatment for the partial, that's means the focal seizure, that is the carbamazepine. If we talk about the absence seizure, absence seizure treatment, absence seizure treatment is none other than, it is ethosuximide. We can talk about, we can also give sodium valproate as a second line treatment, but the drug of choice is ethosuximide. If it is not associated with tonic-clonic seizure, it's a pure case of absence seizure. Remember that if the absence seizure is associated with tonic-clonic seizure, then we can think about usage of valproic acid, sodium valproate. Sodium valproate. What is the one of the important, or I say one of the most common question which is asked from the side effect of sodium valproate is weight gain. Okay, weight gain number one, and number second is alopecia. Alopecia. Of course, the patient will have nausea, vomiting. Also, patient can have. It is a teratogenic drug, right? It can have vitamin K deficiency. Also, patient can have high risk of bleeding. Also, with that, the patients who have who are taking sodium valproate, they have weight gain and alopecia. They are important points you should remember. And any pregnant lady who is on sodium valproate, you need to increase the dosage of folic acid, because the risk of having neural tube defect while on sodium valproate is high. And what is the dosage? 5 milligrams, right? We have discussed about this. And we will now discuss about after absence seizure. We also discuss about tonic-clonic seizure. Of course, the patient with tonic-clonic seizure, the treatment is, again, if there is even a frank or the pure tonic-clonic seizure, valproate is the treatment. any patient who is having now, as I said, like mm, um, the patient is elderly, right, or the patient is a child, we can use the Levitera instead of the valproic acid as an alternative, or lamotrigine also. But remember that levetiracetam is superior than the lamotrigine, because as per the Melbourne guidelines, they say that lamotrigine should not be used alone. So that is what you should remember. After that, once we're done with all of these things, and what we should remember is that is status epilepticus. Status epilepticus. I don't want to, make it very hectic for you. I will just give you a flow chart. You just remember that, and everything will be okay. Any patient who is having status epilepticus, okay, the first thing you will do is you will give lorazepam, or you give midazolam IV, if you are able to secure IV. If IV is not, uh, it's not possible, you can think of IM, intramuscular. You repeat the dose. Okay, if it continues, if the seizure continues, you repeat the dosage of the midazolam or lorazepam. And then if it fails, if the two doses fail, you can go for the second line treatment. And the second line treatment is phenytoin, Levitera, or lamotrigine. Okay, lamotrigine is not that important, but yeah, phenytoin, levetiracetam, or valproate. These are the second lines. If it fails, you can, it is, or we have also phenobarbital also. If it fails, that is what we call as a refractory status epilepticus. And at the time, we have to intubate the patient, basically give anesthesia and intubate the patient. That is what you need to do. That's it. If they ask you, please remember this again and again. I'm telling you, any patient who is having status epilepticus, that means seizures of more than 5 minutes, first treatment is lorazepam or midazolam. You need to repeat. If it fails, repeat it. If it fails, go for the phenytoin, levetiracetam, valproate, or phenobarbital. If it fails, that's called as refractory status epilepticus. Then you have to go for the anesthesia and intubate the patient. That's it. And remember that if they ask you, it is the most common type of epilepsy in a child. It is benign Rolandic epilepsy. Benign Rolandic epilepsy is the most common type of epilepsy in the children, and the treatment is carbamazepine. Okay, after we are done with this, we are just left with one topic, and that is febrile seizure. Febrile seizure. Remember that if there is any patient who is having febrile seizure, you should remember that it is not an epilepsy. Okay, it is not epilepsy. Please remember this. Febrile seizure, if it recurs, it is not an epilepsy. You should remember that. You should remember that. I'm repeating again. Any patient who is like having a repeat of febrile seizure, that's not an epilepsy. Okay, that's not an epilepsy, because the recurrence is really pretty low. The patient is having febrile seizure initially, the recurrence of having this febrile seizure is very low. And what is the risk for having febrile seizure? It is the change in temperature, change in body temperature, which is sudden, likely more than 38 degrees Celsius. The duration is usually 1 to 3 minutes, and the peak age is 3 months. Okay, that is 6 months to 6 years basically. And there is no drug If it is just for 1 to 3 minutes, you have to go for the ABCD. Remember that any patient with the status epilepticus, first step is ABCD. Please remember this. I forgot this. Then you have to go for the other things. Okay. For 1 to 3 minutes with the febrile seizure, no drug should be used. But if it is there for more than 5 minutes, okay, more than 5 minutes, the first thing you use is midazolam, okay, and second step is just like a patient who is having status epilepticus, that is, you go for the Levitera because it is a child, or you can go for the phenytoin, okay, or you can go for the phenobarbital, or you can go for the valproate. This is how you manage a patient of febrile seizure. And all the questions which have been asked, I have covered in this very session. Hopefully, you will be able to answer most of the questions. Remember that uh, one important point is that if they ask you that what is the HLA association of the phenytoin, it is HLA-B 1502. HLA-B 1502 is the association for the phenytoin. Two questions which they ask about the HLA association, phenytoin and allopurinol, both should be in your mind. And ref, repetitive seizures or habitual seizure is same as the what we call as uh, status epilepticus. Okay, habitual prolonged seizure. They say habitual prolonged seizure. The patient is having habitual prolonged seizure. That is basically they are talking about the status epilepticus, where you will go for the midazolam. Then eventually you will think about the rest of the things. Okay, and yeah, that's it. That's more than enough for the seizures. And if there is any question which is asked in your in the recalls, you can send me, and I will try to answer that for you. And at the last, I will just give an idea is that if there is any patient who is having seizures and you don't know the type of seizure, the first thing you go for sodium valproate. Sodium valproate. That is the treatment. That's it.